Hello, I'm Dr. Cesar J. Bravo from Cleveland Clinic, Virginia Tech, and I'll be discussing today the topic scaphoid fractures. When carpal fractures do take place, usually between 60 to 80% of the time they involve the scaphoid. It's important to note that the scaphoid requires twice the force that is needed to cause a distal radius fracture. Therefore, scaphoid fractures seem to be most common with young males, athletes, those involved in motor vehicle accidents, and falls from significant height. Of all the scaphoid fractures, 65% of them tend to take place in the waist, 25% in the proximal third, and 10% in the distal third. When we talk about the scaphoid, it links the proximal and distal carpal row. And when we have a mechanism of injury, usually seen in scaphoid waist fractures, usually an axial loading with a hyperextended wrist and radially deviating, and the radial scaphocapitate ligament tends to behave as a fulcrum and leads to scaphoid waist fracture, which is one of the pathomechanics used to describe this type of fracture mechanism. As previously stated, it tends to take place with those patients between 15 and 40 years old, typically in male population. Talking a little bit about the scaphoid anatomy, we know that the scaphoid bone, more than 75% of it is covered by articular cartilage. It's prone to non-union, not necessarily as in other bones that tend to form robust bone and lead to malunion. And one of the things is the precarious blood supply. Usually 80% of the time is provided by the dorsal carpal branch of the radial artery. And this does form a retrograde type flow, which tends to be seen over here. So as these fractures are injuring, extending into the proximal aspect, they lead to disruption of the vascular supply and possibly lead to non-union. When we're talking about the motion of the scaphoid tends to flex with wrist flexion and radial deviation. The scaphoid also tends to extend with wrist extension and ulnar deviation. One way to remember is that the motion of the scaphoid is the same as the proximal row. Again, flexing with wrist flexion and radial deviation and extending with wrist extension and ulnar deviation. Over the past 2-3 years, we really have learned, as complemented what previously was known with the previous vascular studies of the scaphoid. Now we've been able to describe the vascular anatomy of the scaphoid using microsagittal CT. This was pioneered by one of my mentors, like Steve Moran from Mayo Clinic, who in 2009, they were able to demonstrate that there were two types of scaphoid. One was a full type scaphoid, and the other one was a slender type scaphoid. And that placement along the axis through a dorsal approach was the least disruptive to the vasculature. The full type scaphoid possessed more of a robust internal vasculature network than the slender scaphoid. So I do recommend that you in your practice look at your scaphoid non-unions. They usually tend to be those slender scaphoid type fractures, scaphoids. Like anything in orthopedics, we have to describe our fracture patterns with regards to classification. And our classification for the scaphoids is based on locations, and we refer to it as a distal pole, waist, or proximal pole. And again, the risk of non-union is previously stated because of the precarious blood supply, but also localization of the fracture, meaning the proximal pole tends to have a higher risk of non-union, as well as those fairly comminuted fractures that tend to basically, the more comminuted the fracture is, the more likely you can have a non-union. And again, distal pole fractures are very uncommon, but they occur mostly in children. And due to their good blood supply, they usually have a good prognosis. And again, waist fractures are 70 to 80% of the scaphoid fractures, and 15% of them are in the proximal pole. Initially, the Mayo classification described the distal pole fracture as well as an interarticular involvement with extending to the STT joint, the distal third, waist, and proximal pole. This was then also complemented with Rousset classification, but the most commonly used classification we see in our practice and we use is the Herbert classification. This is based in stable, unstable patterns, as well as delayed union and established non-unions. Usually the unstable type pattern here, as seen in type B, they'll either have a distal oblique fracture line, or they'll have a complete waist fracture line, or a proximal pole extension, or they'll be involved in some form of transscaphoid prelunate fracture area. Of note, as we treat these fractures, it's the outcomes. How do we improve our outcomes with patients with scaphoid fracture? And one of the things that we've learned in our practice is aggressive early treatment, meaning the key to good treatment is early diagnosis, because of the high non-union rate, which ranges from 15 to 40% has been reported. So we want to diagnose these early so we can treat them accordingly and efficiently. And again, scaphoid fracture, the non-union can result in carpal malalignment and progressive radiocarpal arthrosis, but the real effect of malunion is clearly established. As any exam in hand and upper extremity, it's important to note that for the diagnosis of a scaphoid fracture, the clinical examination consists of tenderness along the anatomical snuff box, tenderness of the scaphoid tubercle, and overall, the clinical exam, when we put our hands on the patient, is 100% sensitive and 75% specific. As we move from our clinical exam that moves to imaging, in our hand clinics here at Virginia Tech, we recommend doing 4 views in addition to a PA wrist in neutral. This includes a true lateral, a 45-degree pronation supination view, and a scaphoid view. Remembering the scaphoid view is a PA view with the wrist in ulnar deviation with the beam angle at 20 degrees from distal to proximal. And it's important with this PA view, ulnar deviated view, as is shown here, where we have on the lateral on the left side of the screen that we see in standard PA view, we barely can see the fracture line, but as we do a scaphoid oblique view with the wrist ulnar deviated, we're able to see this fracture line clearly. For occult scaphoid fractures, we know that x-rays are good, but they're not perfect. They're about 75% sensitive. So what is the problem? Well, the problem is that this can lead to late diagnosis, and then that leads to a chance of non-union or vascular necrosis. And the other spectrum, or the other school of thought, is that if we think that we're seeing scaphoid fractures all the time, we're over-treating them, over-splinting, that can lead to loss of work and economic implications. So what are other imaging modalities that we can use? Have been reported using bone scan, CT scan, MRI, and ultrasound. In our practice, MRI is the best test. All are better in ruling out than ruling in, but overall, the early diagnosis is for picking up a scaphoid fracture. The MRI is the one to go and to use. We tend to use their CT scan once we've seen the fracture and we're planning surgical intervention. It's best for assessing the bone in detail, determining the non-union or incomplete union as well in post-operative protocols. It's good for planning the surgery. We're able to measure interscaphoid angles. And it's important to note that we recommend obtaining the CT scan both in the sagittal and the coronal plane of the scaphoid. As is shown here, the plane of the scaphoid and the axis of the wrist shows the proximal pole, but once you do the X-ray, you line the beam in the long axis of the scaphoid, you're able to see the bigger fracture fragments. And again, these are 2 separate fracture patterns described in the X-rays, but basically it's just angling the beam in the correct view that you're able to identify the true correct fracture line of the scaphoid. And again, do it in the sagittal and the coronal view of the scaphoid. Well, once we know the fracture, the ability to detect displacement, well, this was compared. There was 2 good studies done by Temple and Busi, and basically Busi's study, they used arthroscopy as a reference standard, and they were able to show that CT was more accurate in detecting displacement and instability than radiograph. It was not perfect, but definitely far more reliable. And again, far from perfect agreement, but better. MRI does have high sensitivity and specificity, both greater than bone scan and immediately positive. It's very good to also identify soft tissue changes in bone contusions as well. In some studies, they reference this as a vascularity. Some question, though, that it really does not show vascularity of the scaphoid. For us at Virginia Tech, the suggested algorithm, usually we get x-rays early on. If those are positive and we're thinking of surgery, then we get a CT for surgical planning. If the x-rays are negative or equivocal, then just to kind of gear our treatment, then we do a limited wrist MRI, because this actually dictates how long we mobilize the patients and if we were to proceed in a non-surgical manner. And CT, if needed, then subsequently surgical plan is carried out. From treatment, ranging from non-surgical treatment to surgical treatment, what are those scaphoid fractures that we can treat non-operatively? Those are stable fractures those fractures are non-displaced, meaning displaced fracture, and those involving the distal pole. For us, we recommend operative treatment for those unstable fractures. Percutaneous fixation can be used. You can do ORIF either through a volar or dorsal approach, and sometimes may require bone grafting. And we'll touch a little bit about those as we go specifically through each specific treatment type for the scaphoid fractures. A little bit about non-operative treatment for scaphoid fractures. One of the things that this landmark article was they were able to show very nicely. It was randomized, multi-center study, and basically either there were CT or MRI scaphoid waist fractures with minimal displacement, and they were able to show that a short arm cast without inclusion of the thumb was actually adequate, and they were able to see the scaphoid fracture unite within 10 to 12 weeks. So this has been a change in our practice. We don't, if they're minimal displaced and we treat non-op, we just do a short arm cast, then subsequently proceeding to a regular wrist splint. This other study, which is good to know, specifically for non-operative treatment of acute scaphoid fractures, they were able to look at 4 randomized controlled trial studies, more than 500 patients. They looked at above, below the elbow immobilization, including the thumb, not the thumb, doing it in wrist extension versus wrist flexion. All in all, what they were able to note was that there was no difference in union rate, pain, grip strength, time to union, osteonecrosis. So again, it falls back to immobilization in the wrists, a short arm cast in neutral, it adequately performs the job. Specifically, though, they have to be an undisplaced scaphoid waist fractures, and that's how what these studies looked into it. As we move from non-operative treatment, we move to operative treatment. Operative treatment, what are the indications? In some populations, some acute non-displaced fractures, people would say that if you're able to see a fracture line, that you're more likely to fix this. Other indications for operative treatment include unstable fractures, proximal pole fractures, and if you want to avoid prolonged immobilization, some advocate, again, for the non-displaced pattern proceeding with percutaneous fixation. We'll also talk a little bit about non-unions that do require operative treatment, and then those can range from needing a vascularized bone flap, the approach, fixation, correcting the humpback deformity, and we'll go ahead and address a little bit of those in each upcoming slides. What about for surgery for non-displaced scaphoid fracture? Those are the ones that you barely see the fracture line. Well, in 2008, they were looking at these evidence-based medicine, 2 separate reviews in the literature, one by Graham King and his group, and Dr. Chung and his groups. And basically, they concluded no difference in union rate, except Diaz in the JBS 2005 did have 10 non-unions with cast immobilization. And they quoted that perhaps quicker return to activities worked, significant complications were noted with surgery, and basically, they recommended to provide a patient-specific treatment. Those patients that may not tolerate long-term immobilization, may have an earlier, quicker activity return to work. That's when percutaneous fixation may be considered. But again, patient-specific treatment is what was recommended. Again, Boozy and his team, they looked at a systematic review of randomized controlled trials in JBS 2010, and they were able to know that ORIF for acute non-displaced fractures, they reported patient-reported functional outcomes were better, patient satisfaction was increased, grip strength was better, shorter time to union, and an early return to work. But they noted, though, there was no difference in pain, range of motion, non-union, malunion, infection, complication, and total treatment costs. So this is something to have in your armamentarium as you're advising your patient specifically for acute non-displaced scaphoid fractures. If we were to do the percutaneous scaphoid fixation versus casting, this article in 2001, they were able to know the union rates, time to healing was quicker with the percutaneous fixation. And again, going back to the early return to work, but motion and strength, again, at 2 years, cast and percutaneous fixation, once the fracture heals, there's no difference. The other one that we need to discuss is what defines as an unstable fracture for a scaphoid. We define a scaphoid fracture that is unstable when it involves the proximal pole, where there's displacement more than 1 millimeter, when there's humpback deformity, and this is determined by the radiolunate angle greater than 15 degrees and interscaphoid angle greater than 35 degrees. Those fractures that involve perilunate, greater arc type injuries, those are unstable fractures of the scaphoid that need to be fixed when there's significant comminution, when there's a vertical fracture line. Of note, the principles of fixation is adequate reduction and stable fixation. So we know the screws are better than pins. Better placement, there's two school of thoughts, is central third placement versus perpendicular to the fracture line. I think it's depending now in my practice, I modify with regard to likely I try to do a central third placement, but I also not hesitate to go with perpendicular to the fracture line, especially in those those scaphoids that are non-slender, that are fairly bigger because there's more micromotion, and those more likely I tend to go perpendicular to the fracture line. Percutaneous fixation, as previously stated, indications can be from non-displaced, unstable fractures, non-union, requiring structural bone graft. This can be done percutaneously through a Volar approach, and this is more for distal fractures and unstable fractures. Those that we recommend doing the dorsal percutaneous is those proximal pole fractures. You can also combine an arthroscopic assisted technique. It depends on the attending's preference, and again, may aid the reduction technique, the reduction in of the fracture. But you have to do the arthroscopy through the metacarpal view in order to actually see the reduction of the fracture. And again, you're able to assess the congruency if you're doing arthroscopically assisted. Arthroscopically assisted, as was showed by Dr. Slade in 2002, they were able to show 100% union. Average time to union was 12 weeks. But one thing in this paper by Dr. Slade at that time, they were able to show that those that were treating within the first month arthroscopically assisted were the ones that really healed faster than any other subgroup. As we move from percutaneous and arthroscopically assisted approach, the open approaches. When to do a dorsal or Volar approach. Dorsal approach usually is indicated in associated carpal dislocation, ligament disruption, such as a greater arc injury, or those involving the proximal pole of the scaphoid. The Volar approach is indicated for common unit waist fractures, those that involve and have a significant humpback deformity in the chronic area, or chronic fractures that we tend to recommend doing a Volar approach. One thing that has changed in my practice is the Volar approach as described by Garcia Elias, which is a nerve-preserving volar capsular approach to exposing the scaphoid. You use basically your interval between the radioscaphoid capsule and the radioscaphocapitated ligament, and you're able to elevate a C-plasty and get a full end phase view of the scaphoid. Important when you're treating scaphoids with humpback deformity and open fashion, you first have to reduce the DC component, and that can be done through a radiolunate pin and placement of, and that would correct the humpback deformity. Then you place your bone graft and your screw, and this is a stepwise approach of correcting that DC deformity, getting your alignment, correcting the length of the scaphoid, and then building from that after you've put in your bone graft. Union rates, if you look at dorsal versus volar approach, there's not much different. They look for example, this study by Polsky, they were able to show that healing, pain, motion, and strength was the same looking at both volar and dorsal approach. Important to note that when you're doing the post-op follow-up in these patients, you do have to follow them closely. I would recommend doing 4 views as you go with your x-rays, including that scaphoid lateral view, as is shown in the middle picture. But then once you get to that point, especially for defining, we do tend to get CTs in our clinic, and what we're looking is for more than 50% of bridging of the bone. And that would more likely, it's especially in high level athletes, that's where we were to say, look, this is, we can release them back to play. A little bit about proximal pole scaphoid fractures. Treatment of proximal pole scaphoid fractures can be challenging. There's been described as open reduction to fixation, but also in some studies have described excisioning of the proximal pole. Garcia Elias in 2001 described 2 subtypes of scaphoid proximal pole fractures. He described a type 1, which was a small osteochondral fragment that is proximal to the palmar and dorsal scapholunate ligament. A type 2 was one that was distal to the palmar and dorsal scapholunate ligament. The type 1 usually has poor vascularity. They rarely unite. They do have an intact dorsal and palmar scapholunate ligament, and this may be excised without causing carpal instability. In their subset of patients, in their series, they were able to know full pain-free range of motion, but they did report some loss of grip strength 15% of the time. But this is a type of fracture that if you see a type 1 osteochondral fragment not involving that scaphoid lunate ligament, both the dorsal and palmar aspect, then sometimes resection can be done. That's for the type 1. Type 2, they do have better vascularity. They're more likely to heal. And these are the ones we tend to likely fix and not remove, because if you were to remove that, can lead to carpal instability. Again, because the fracture is distal to the palmar and dorsal radiocarpal ligaments and scapholunate ligament. For proximal pole open reduction and fixation, one of the things to consider in your practice, you can consider doing a dorsal approach. In addition to doing your reconstruction, consider a temporary scapholunate pinning or scaphocapitate fixation. In this study that we were able to note that at 12 weeks, time to union was 3 to 4 months. It does require prolonged mobilization, and that sometimes that scaphocapitate screw or pin the pin specifically can back out, can be irritative. So do recommend, if you do put the scaphocapitate pin and you leave it buried under the skin, do follow your patient on a 2-week interval, and hopefully once you get to the 4-week period, then you can remove them without any issues, and you can do that on the local in the clinic. Proximal pole excision, as previously stated, will it cause instability? Again, if it's a type 2, more likely, like as we previously stated, Garcia-Elias type 2, more likely to lead to instability. Some of the pros that say, hey, for this type 1 excision, they're lower risk of complications, no prolonged mobilization, minimally invasive. Again, the cons are carpal instability. A little bit about vascular necrosis of the scaphoid. We tend to think that and define a vascular necrosis of the scaphoid, it's that it's absence of any convergent reticulate between fragments. Typically diagnosed by MRI, CT findings with increased radiodensity. Some MRI studies have actually questioned if you can actually detect a vascular necrosis through the MRI. But what we report a vascular necrosis, we think of it as a scaphoid hypoperfusion, and it's mainly when there's absence of convergent reticulate between fragments. A little bit about vascular necrosis, scaphoid hypoperfusion. This is what I would recommend you think of it. And in terms for the scaphoid fractures, especially for the proximal pole, the literature is not clear regarding its importance. There's level 4 evidence to support both either using non-vascularized bone graft versus bone grafting. There's 2 types of bone grafts, either the free bone graft, pedicle, and the pedicle bone graft. When you consider the pedicle bone graft, one of the ones that's the workhorse in my practice is the palmar radiocarpal artery flap, as described by Mathullin. Here's a picture of that palmar radiocarpal artery flap here in the bottom. You can also consider dorsal pedicle grafts based on the retinacular capsular vessels, either the 1,2 ICSRA, that tends to be one of or the dorsal capsular flap. But again, level 4 to support both sides of using bone and pedicle bone graft versus not. But the free graft in itself uses the medial femoral columnar graft as the workhorse, and it's based on the descending genital artery, or the supromedial genital artery can be used when the descending genital artery is not present. This has been shown by Higgins and his group, as well as in others, that their time to union was about 13 weeks. Even in these complicated revision cases, they were able to get good union. One of the things that we learned, as Dr. Higgins did one of his instructional course lectures with us, that those that they found more issues with, and those that found more problems at the donor side, were in overweight patients. And he did suggest that in overweight patients that maybe something else can be considered with regards to other alternative methods, because the higher risk of complications and the indication for a medial femoral graft, it should be reconsidered. One of the things that they also talk about is the lateral femoral trochlear, medial femoral trochlear graft, and we'll mention that in the upcoming slides. For scaphoid non-unions, as we move forward, this non-union of scaphoid, it does increase with more proximal fractures, displaced fractures, delayed treatment. And again, proximal pole fractures have a high risk of non-union, as does the displaced fractures. Even with treatment of these fractures, the fracture may not heal. Usually surgery is required, but it's not always successful. Waist and proximal pole fractures that become a non-union or malunion will often suffer carpal instability, degenerative changes in AVN on the proximal pole. So this is something to be mindful. And again, the longer the non-union has been present, the harder it is to treat. So in my practice, once they have a non-union that's more than a year, then at that time, I'm more likely considering salvage type procedures. Non-union, again, can result in carpal malalignment and progressive radial-carpal arthrosis, but the real effect of malunion is less clearly established. If we looked at non-unions, how do I think of it in my practice? Well, one is I want to address the alignment. You want to correct the humpback deformity and the DC deformity. You want to provide good stability. And again, this is required for healing. This may be 1 or 2 screws, depending on the architecture of the bone. But basically, this is when really good carpentry comes into place. Vascularity does AVN increase with persistent non-union and not at all phenomenon. Again, this is a spectrum of what I believe and I've seen in my practice, and it's more of considered of a scaphoid hyperperfusion. You know, in my practice, vascularized bone grafts are considered for those proximal poles, especially those proximal fifth, because, you know, in that aspect, if you have a component of hypoperfusion, in addition to very proximal, this is when vascularized bone grafts do come into play. When you have a persistent non-union after attempted surgical treatment, and when you have non-salvageable proximal poles, one of the things to consider in your practice is the medial or lateral femoral trochlear flap, or costochondral rib graft, proximal hammy graft. One of the things with costochondral grafting technique, it really has demonstrated excellent union rates and functional outcomes. With the hammock proximal graft, it has the advantage of being a local donor site, but has limited reported outcome data with only single case reports published. So these are other things that when you're missing, and is a lot of the cartilage is non-salvage proximal pole, these are some alternatives to include in your armamentarium. But of note, what are the facts? Well, when there's a proximal pole AVN, union usually is achieved about 88% of the time with vascular graft versus with screw fixation and non-vascularized wedge bone grafting. The 1-2 supravernacular artery graft leads to a union rate about 70% for scaphoid non-unions and 50% for AVN. And this is just what the studies and the data show. The risk of failure is higher when there is DC and humpback deformity. Again, underscoring the need to restore your scaphoid geometry. Again, this is when it becomes a really good carpentry work with regards to the surgeon recreating that anatomy and the scaphoid length and height. One of the things that is interesting to know that for the proximal pole, that those that develop hypoperfusion, or what we refer to as early avascular changes, Dr. Wolf and his team in the Scaphoid Non-Union Consortium group, they were able to demonstrate that independent of proximal pole vascularity, they were able to get healing without having to use a vascularized graft. And they were able to show healing by 3 months in CT scan. Again, 33 out of 35 is pretty good. And again, this underscores the importance of creating good architecture. And this is not only for proximal pole, but in a sense for scaphoid waist fractures as well. Well, other things to know, what has changed in my practice and something that as we teach our fellows. Well, one thing is outside the box thinking. What for percutaneous screw fixation without bone grafting and delayed union is viable and it's a good option, but you have to have intact scaphoid fracture architecture. You need to make sure you don't have any clear radiographic evidence of vascular necrosis of the proximal pole. Again, the delayed less than 1 year is of key importance, as well as known signs of vascularity, minimal to non-bone resorption in CT, and not a whole lot of sclerosis. And again, no significant medical comorbidities. And at times, this is when percutaneous screw fixation, even though if they have those 60 changes, you're able to get healing. In addition to what has changed in my practice, in those screws those scaphoids that are fairly bigger, that are non-slender, sometimes doing 2 screw fixation adequately provides more stability fixation. And that, what does that avoid? It avoids the rotation. And I think in a subset of patients that have fairly large scaphoids, you may have some persistent rotational instability, and that can lead to fracture site non-union. Important to know when you're doing double fixation with your screws, one is the coronal fixation when you're doing retrograde. In the lateral view, they'll look parallel. In the AP view, they'll look in the lateral view, they'll look in a single line, and then you'll see the 2 screws in the coronal view. If you're doing an antegrade fixation and a sagittal fixation, you'll see them in the oblique view as a single screw, but in that oblique view, there'll be 2 screws. So this is just something to note depending on the trajectory you're coming, either antegrade or retrograde. In addition, one thing that we also advise our fellows is always look at the lunate. I mean, this article really did show a good reference of the more likely that the type 2 lunates were more likely to progress to non-union when treated operatively and non-operatively. So maybe in those patients that have this subtle displaced fracture, they have a type of a scaphoid, either proximal or waist, have a type 2 lunate, more likely aggressive treatment, early rigid fixation might be indicated. And this was shown by Dr. Richard and their group at Duke, and they did a very nice study where they were able to show that these type 2 lunates were more likely than type 1s to progress to non-union. The lunate facet size was not shown to be significant risk factor for non-union among the patients with type 2 lunate. Additionally, for those that we do treat a proximal pole non-union, again, just mentioning you can also consider an arthroscopic assisted reduction in grafting technique. And you can also, in addition to your scaphocapitate pin or your radiolunate pin, sometimes you can do a scaphoid to lunate screw, like a Rassel type procedure. And that has been shown by this group by seeing that they were able to get good fixation. And this is just somewhat thinking out of the box, but this can be done by indirect fixation of the scaphoid proximal pole and then stabilizing both the scaphoid and the lunate to allow healing. One last thing to note is that in subset of patients that do have a scaphoid waist undisplaced fracture, a subset of these can develop traumatic non-dissociative carpal instability. And this goes with the initial index pattern of injury. Basically, this patient will present to your clinic with just a simple scaphoid transverse fracture that you're treating either non-op or just percutaneous fixation. And then subsequently in close follow-up, they'll start either developing VC or DC. And in these patients, that's when you need to consider that they may have a traumatic non-dissociative carpal instability. Excuse me. And this may be either because the DC or the VC restraints have been disrupted, as shown in this picture, and that can lead to that carpal malalignment. One article that I would recommend for you guys to read and reference is this article that was published in the Journal of Hand Surgery European volume that talks about acute scaphoid fracture, making decisions for treatment for this troublesome bone. It really covers the diagnosis, the assessment, the cast, the surgical treatment, the proximal pole, the assessment of union objectives of treatment. And this is what this talk was based on. And this is a good reference to have in your armamentarium. In conclusion, have a high index of suspicion for these patients that come in with the mechanism of injury of hyperextension, radial deviation, have pain on the anatomical snuff box. Utilize your imaging modalities for accurate diagnosis, understand your indications for treatment, be aware of the high risk of non-union, and again, a missed fracture may lead to carpal collapse and scaphoid non-union advanced collapse arthritis. Thank you.